like, that's not a soldier in there, that's a patient, you need to treat him, and blah, 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 just ripped her open for 10 minutes where I could hear it, which was nice.
That was called distraction.
It was nice. And she came in and she was like, I'm so sorry, you will never see her again, this is not how we operate, and I never saw her again, and it was great.
But do you see, that wasn't that long ago.
No.
And see how we unfortunately have our minds set, well, people just complain and it's unwarranted, but it's not. Everyone has a different concept of what that pain is. Yes?
I have twins who are 2 and they do that to each other. Like, I don't even have to tell them that the other is sick and they just know it, and they'll like go over and hold each other's hand.
See,
there's
there's something.
Their head. It's like they just know.
It's instinct,
Really weird.
instinct.
Yeah.
See, that's awesome.
We don't know.
Why does it take us so long to realize? See, now they haven't had any nursing. the 2-year-old twins, right? Instinct of the concept of pain. It's very important. And you know, we used to fly through that chapter about pain. You know, okay, give them something for pain and move on, right? But I think it is important to have this discussion, to make sure you have a good, strong foundation of the importance of assessment and follow-up. Don't just give pain medication and then forget to do a follow-up. You have to do follow-up, reevaluate. You have to find out what you can do to eliminate or at least take the edge off of the pain as much as you can. And here's some other concepts. The TENS unit, and they showed some images on some of those video streams about TENS, how it does the stimulation. It actually, it's sort of like a block, a distractor. It initiates a different type of sensation, thereby making the focus on that rather than the acute pain. Acupuncture has been well received, more so in recent years than, it's not been blown off as just folklore, as they used it. Ancient Chinese societies did. Massage, and let me tell you, last night I was used with my husband after the dentist. It was helpful, The application of heat and cold. I told y'all, I think I told y'all, I have my heat pad upstairs.
Mm-hmm.
Yeah, have it waiting for me, right? But here's the thing I do want to emphasize in terms of heat and cold applications. You guys have to keep a watch on these applications. No longer than 15 minutes should it be applied. Never applied directly to the skin. Because it can create other damaging situations. And I'll tell you, I had situation where I liked my heating pad. I used to sleep with a heating pad all the time, and I'd tell my husband, bring my heating pad in for where I had some surgery. What was it? I can't remember what the surgery. It wasn't. Well, it could have been. It might have been at the time that I had the exploratory surgery associated with appendicitis, but I can't remember if it was that. But I recall falling asleep. The nurses didn't know. I just had my husband bring in the heating pad, see. And I was being bad as a nurse, because I know it's supposed to be checked out with the maintenance crew or whatever. Everybody should know. But see, I had that heating pad and I just laid it over top of my stomach, went to sleep that night. Next day, had these blisters. And I had to tell the OB doctor, I said, now don't jump on the nurses, it was me that did it, because he was ready to jump on them, see. Because he was thinking, well, I'm going to file a lawsuit. right? I said, no, that was me. But you guys be very cautious and careful if you do use applications of heat and cold. Distraction, we talked about distraction. And music should be available for all patients. I think music therapy is good for any age patient. I mean, even babies, they have those little musical mobiles in their beds, right? So music is a wonderful thing, and I frequently in the ICU would tell my family members, bring in whatever kind of music their favorite music is, and I'll play it for them, you know, because it takes them to a different place. Music is good. And then, of course, I had to put on that scene from Canyon Lake, right? I always use that scene now.
And there's always a nice breeze to go with that picture.
Yes. I mean, you're imagining that breeze, aren't you? See? That's just that just takes you to a different place. See? Yeah. Darker. See, that takes you to a different place. Right? It does. It's beautiful. They need to put that on a picture postcard. Some things about pharmacological pain relief measures. The thought of considering round-the-clock dosing. If we cut it to the chase and we medicate them like with scheduled medication, we'll have more control of the pain. We'll be able to have the patient do more in terms of activities, getting them up faster, being more mobile. Because in essence, if we get them up post-op sooner and faster, we are more apt to recover faster and have less complications. There's some concerns about some analgesics, Tylenol. We would not want to give 10 Tylenol, would we? Some of y'all will never do that again, will you? Remember, if you have some pharmacology math problems, which you will this Wednesday, bring your simple calculator, right? Be reasonable. You wouldn't walk into a room and give them 10 Tylenol. I mean, here. Right? No. Be ever so cautious with the use of Tylenol in patients that already have some liver insufficiency, some liver failure going on. You want to, of course, tell them to avoid alcohol anyway. Aspirin, notorious for causing gastric irritation. Consider having those enteric-coated use or giving with food. Opioids, you must be cautious with the side effect of respiratory depression. That's the NCLEX answer, guys. You have a patient that has been administered morphine. What do you have to be concerned about? What's the most significant concern that you need to answer is respiratory depression. That is the NCLEX answer for that one. Routes of administration. You have what they call PCA pump. That's just an illustration of what one might look like. In the hospitals, when y'all go in, you may see some patients with PCA pumps, and that's where they can actually control using a little handheld device, and they can click it, and they have that machine where they got it dialed in to administer so much. And this is just the example of what, this is the vial that's inside here. That's just an example. It's Demerol for this example, but it could be anything, morphine or whatever. But it allows for so much pain relief. It gives you a lockout time. Usually they have a lockout of 10-minute intervals. And it does work quite nicely for those patients, those post-op patients, so you'll frequently see PCA pumps on med-surg floors. You have different types of nerve blocks. I mean, how many people's had babies? Did any of y'all have any of these nerve blocks administered to try to deaden that pain or avoid the pain, eliminate the pain? Transdermal, those are the skin patches, fentanyl patches. Some of y'all see those in your nursing home patients, right? Rectal suppository might be used for temperature, maybe Tylenol suppository, or for bladder spasms, you might actually see a patient receiving a B&O suppository. That's got an opioid kind of compound in it to help relieve some of these spasms. Of course, injections. IM injection. Now, IM injection, and in the Unit 8, I've actually got a few slides that we address about that. You guys, now, in your ATI medication 1, 2, and 3, did it give you a description of different types of injections? Which one of those ATI presentations, the videos? Did it, y'all recall? Somebody taking the ATI skills?
Yes.
One of those, did it cover medications and dealing with injections?
Yes.
Did it talk about locations for injections? Did it? Different locations for different types of injections? You guys make sure y'all review that before you do your high stakes testing, right? Say yes, yes we will. We'll make sure. Well, let's just make sure we don't try to do an IM injection into the cardiac region. Right? We wouldn't do that, would we? Never. Let's don't. Y'all go back and review those acceptable sites for injections, is what I'm trying to say. Then they have if they have such serious issues with pain, they can sometimes do some surgical interventions. And these are listed in your book. I just pulled off a slide here. This is just an example of one type, that rhizotomy. And it's basically, these are procedures where they can figure out a way to cut the nerve sensations to affect the discomforts that are felt. But these would of course be surgical procedures that a doctor would do. That's just some of them. Misconceptions that interfere with pain management. We must remember over and over, I say it's what that patient says it is. And if you are not relieving that pain, you should take that next step and contact the doctor and say, this is not cutting it, we need something else. Do not be afraid to call the doctor and say, we need something else to help the patient. Because we can always go back to that slide that it took me 2 hours to create. Right? That's all you got to remember. Placebos, and that's in your textbook, talking about placebos, ever so short of a verbiage, right? It's not ethical to actually use placebos. It's just not really, because we're lying to our patient, aren't we?
Yes.
In essence. Ethically, that is not a wise thing to do. So we shouldn't do that. You know, even when I was in practice, well, of course I'm in practice, but I'm saying back when I first started, I recall patients that we'd have patients, the psychiatrist would have patients admitted into our MICU, and he would actually order placebo of saline injection for as a medication to give, and he would tell us to use that. But see, and which we did, you know, because that's we followed what the doctors told us to do. But it's not. It really wasn't. It's not ethical, is it? Because we're telling them, we're giving them this to alleviate their pain. Maybe psychologically, maybe it does improve their pain. But we can't really say, and we shouldn't say. What we should do is correct practice is pain is what the individual tells us it is. See, placebo's not a good thing. We learn from research, evidence-based practice, how things change. Years and years ago, to treat schizophrenia, they thought, let's do this treatment, let's just load them up with, give them a mega dose of insulin, put them into a coma till they seize. They used to do that years and years ago, I mean, a long time ago, but see and show research, of course, what that is, destroyed brain cells. See, but that was a treatment modality for treatment of schizophrenia. Then if y'all refer to your pages 748 and 49, it talks about, shows you about the nursing diagnosis care plan about acute pain and bipolar y'all can refer to. And I wasn't sure if Ms. Alexander put out a blueprint yet. So I did cut and paste into my slides at least my parts, okay? And though she's the one that will select, I pulled out 30 items from these 2 chapters. And I tell you, if you'll just review what I've talked to y'all about, what I've lectured over in these slides, you'll do quite nicely for my section. So I know Wednesday is the exam, so one of y'all might want to email, say she gonna, put up the blueprint.
So you getting 30 questions?
No.
Oh man.
She'll probably pull 20.
Are y'all both
All right.
gonna be in here for the exam in case we have questions? Since
I
that's-
can be, she's gonna administer it, but I can be available for my part. Yeah. Maybe, sometimes.
It's very helpful, especially for certain questions like,
Yeah. Oh, I can't answer her stuff.
yeah, come up to her before going to, oh, that's more. I don't understand what's
Okay, so guys, for this last bit of time, in probably 30 minutes, if y'all want to break up in your groups, I want y'all to talk about these specific items, especially like those mastery exercises and NCLEX style review questions that you have for those 2 chapters of mine. I want y'all to remember when you come on Wednesday, bring a simple calculator, right? Because you're going to have, I don't know how many math, could be 4, I'm not sure. But please be reasonable. If it doesn't make sense, don't say you'll walk in and give 10 Tylenol. You know what I'm saying? Let's have some reason here. Any questions? I think at 10:30 everybody should be done in their groups. Do y'all have a test today or not in farm?
Yes.
See how kind I'm being for you guys? I'll give y'all this, after 10:30, I'll give you that independent study time for farm. And if anybody wants to come up and look at test 6, unfortunately, I have put those white papers in with another group of tests, but I do have the answer key. So I don't know